Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We are so happy you joined us. We are going to have a continuation along the lines that we've been discussing for the last few weeks around self-preservation. And without further ado, I'll turn it over to our founder, Dr. Randall Maxey.
Good afternoon, and thank you, Dr. Barbara Davis Stevens, and thank you, our guest, for joining us. We are going to continue our discussion. One of the things I'd like to talk about is why we have so many diseases. Dr. Walks impressed me last week saying, are there any statistics that we are not at the top of when it comes to health? And unfortunately, right now, for the majority of these diseases we're going to discuss today, we do have severe question. I want to start with the first slide, but we ended up with asthma last week, which we're going to go to, but I just want to quickly review what we talked about. And we talked about how to recognize some of the signs and what you should expect. So I just want to have a limited conversation about these early slides and then go back into depth when it hit asthma. Is that okay? Simon, would you start the slides, please? Okay. On this one, we talk about hypertension. And hypertension is also called high blood pressure. And many people have hypertension, but most of them don't know it. It's also known as a silent killer because it doesn't have symptoms normally, but it can have headaches, it can have shortness of breath, nosebleeds, chest pain, and some vision changes. But you want to make sure your doctor checks your blood pressure well with a cuff on your arm. That's better than the wrist cuffs and the finger cuffs, and probably should do an electrocardiogram and a few other things, and draw blood looking at your urine, in particular the protein in your urine and a renal panel. Dr. Neighbor, would you take the next slide?
Certainly. Our first line treatment for hypertension consists of lifestyle changes, such as following a low salt diet. One commonly recommended is the DASH diet, weight loss, and participating regularly in exercise. Drug therapy, notice I didn't say pharmacologic, Dr. Walks, often starts with thiazide diuretics, ACE inhibitors, ARBs, or calcium channel blockers. And very often we have to add on additional drugs so that we have what's called combination therapy. And we need to monitor for medication side effects as well as adherence.
Dr. Walks?
Type 2 diabetes mellitus. You said we're going to go through these quickly as a review, Dr.
Yes,
Maxey. Is that
yes,
correct? Till we get
correct.
to asthma. Okay. Um, Diabetes is something that I remember growing up seeing friends, parents lose feet and then lower limbs. And diabetes is something that has been with us in our community all of my life. And folks ignore the going to the bathroom a lot and being thirsty and the blurred vision and then things that don't heal very well in the extremities. We now have a little bit better diagnostic technology, like looking at your hemoglobin A1C, um, looking at your fasting glucose. There are other signs for insulin resistance, but the main thing is to acknowledge that this is a killer in our community and has been for a long time. And we'll hear things like, I heard someone say, well, I came into this world with 2 legs and 2 feet, and I'm going to leave with both my legs and both my feet. And it's tough. Diabetes really is tough in our communities and in our families. The vision changes scare people like me. I've been wearing glasses since I was 7 years old, and the thought of having my eyesight go away is usually enough to scare me to back away from the cookies and cakes. I still eat the French fries, Dr. Maxey, but we need to make sure that we're taking care of our health.
Thank you. Let's go to the next slide. Is Dr. Lawson on?
Dr. Lawson is on.
Yes, I am.
You want to take the next slide?
Well, right now I'm looking at a slide. So it shows diabetes type 2 and make the prevalence. Okay. And here we go, chronic kidney disease. Symptoms, early signs, asymptomatic, fatigue, nausea, anorexia, pruritus, edema, altered urine output in advanced stages. Diagnostic pearls, defined by GFR less than 60, albuminuria, greater than 30 for greater than 3 months. Monitor protein in urine, monitor creatinine trends, and use cysteine C if needed. Kidney ultrasound helps exclude obstruction or structural disease. The rest of my slide has not been shown yet. If you can move, whoops. Can you move it up a little bit?
We're
There.
just going to quickly, we're just doing a quick review.
Right. Treatment, control blood pressure, diabetes, and lipids. Use the SGLTZ inhibitors and non-steroidal MRAs for kidney protection. Avoid nephrotoxic drugs. Refer to nephrologist for stage 4 plus resistant hypertension or rapid progression.
Yeah. Let's go to the one on cardiovascular disease, Simon. And in this one, we talked about occasionally have chest pain, which is called angina, sometimes shortness of breath, palpitations, which are abnormal heartbeats, dizziness, and fatigue. And some women may present with atypical chest pain. Sometimes they get turned away from emergency rooms, even though they're having a heart attack in some cases. But make sure that you get an EKG to draw blood for the enzymes to tell you if you're having a heart attack. Some people may do an echocardiogram, which is sound waves through your heart, and they may want a stress test, a CT angiogram for evaluation of ischemia, and they want to do a blood looking at your CRP, looking at your lipid panel, etc. And we can see that Black people have more heart disease than other people. Now we're at asthma, and we can start here with Dr. Neighbor Siebens. We can go into
So,
detail in the
so,
next
so
slide.
Dr. Maxey, before we leave the cardiovascular disease, you mentioned something I think that is worth us just hitting a little bit more. The atypical chest pain, that jaw pain, or that nausea. A lot of times, folks want to focus on some of the technical words that we health professionals use to describe things. And I think it's important to know that maybe angina or chest pain or angina is it's nice to know what that means. But when we have something going on, if you go into the urgent care or you call your doctor and you're trying to describe what's happening with you, if you know that a pain in your jaw or feeling like you're going to throw up could be a sign of a heart attack, and you describe that, you don't need to know a lot of fancy words to have your doctor understand that what you're describing could be something that's related to a heart attack, and then ask the right questions. And I use the term heart attack as opposed to what, because people know what I mean when I say heart attack. So I just want to point out the fact that so many times we are busy with these medical words, or these what we used to call these $5 words, and we really just need to describe what is happening to us and what our concern is, and hope that the doctor or the practitioner can translate that and ask the right questions and order the right tests. I'm not going to talk to you about angina, but I might tell you I got some chest pain. So,
Good point. Dr. Neighbor Siebens, was this one on asthma?
Well, asthma is something that we see a lot of, especially in childhood, and you don't grow out of asthma. Your symptoms may become less noticeable or less frequent, but the underlying pathology is still there. When you're having what's known as an asthma attack, you have wheezing and difficulty breathing and tightness in your chest and coughing and breathlessness. All of these can occur uh, at any time when you are having these symptoms at night a lot. You may notice it, but they are certainly not just a nighttime occurring symptom. In adults, they can do breathing tests and measure how much blockage there is in your airways. You take a tube in your mouth and blow as hard as you can for as long as you can, and they measure. Children, not so much. We don't do spirometry. We listen with our stethoscopes and we talk with the family and with the child if they're old enough to respond and get a handle on what it feels like that they are experiencing, when it is that they are experiencing it, and if they've noticed that anything in particular sets them off. But by whatever method you go to get to the information from the patient and the family, once you establish your diagnosis, then you get to the treatment phase. Now, severe asthma, well, asthma is a different disease than COPD. COPD is chronic obstructive pulmonary disease. However, untreated, undertreated, and long-standing asthma can lead to and develop into COPD in adults. The treatment is stepwise with bronchodilators, which mean you open up the airways with drugs and steroids. And there's some newer drugs that help and that are very helpful. But the main thing is to, if you know what sets you off, that's known as a trigger, avoid it. And like for children, if they know that running sets them off, then we advise them to take their medication before they start running so that they won't get into trouble.
Well, thank you so
Next
much.
slide.
Thank you. Yeah. And Simon, can you make
Next
that?
is sickle cell.
Can you make the slide bigger, Simon? Okay. Dr. Lawson, I know you're a psychiatrist, but could you talk about sickle cell a minute?
Absolutely, especially after we did a publication a couple of years ago showing that the sickle cell and major depression, unfortunately, often co-occur together. Sickle cell is a risk factor for major depression. Symptoms: pain, crises. That's the one that gets all the dramatic focus. These crises, which can be really disruptive and actually ends up with folks leaving the workforce and became not being able to do much in terms of recreation. Anemia, jaundice, delayed growth, splenomegaly, infections, and stroke risk in children. Diagnostic pearls: hemoglobin electrophoresis confirms diagnosis, looks for Howie Jolly bodies on smear, high reticulate count, low hemoglobin, transcranial Doppler in children to assess stroke risk. Shrink the size, please. Could you have them shrink the size? Because mine is not. There we go. Treatment: hydrouria increases HbF and reduces risks. Reduces crises. Regular transmission for high risk stroke prevention. And I might add, just came from a recent talk emphasizing that many African Americans simply do not get these or have access to these treatments. Folic acid supplementation, bone marrow transplant may cure selected patients, and there's a controversy about should Medicaid pay for it. Vaccinations and prophylactic antibiotics to prevent infections. So this is a chronic, common condition in our community, but the financial resources for the government, as well as many healthcare programs, simply do not support many of the effective treatments.
Okay. That's neighbor Stevens, and that Walsh care to comment further on this?
I do. I want to make it remind everyone that in this country there is mandatory newborn screening for a number of diseases, one of which is sickle cell. And it's done in the nursery. The reports typically are not back before you discharge from the hospital. So it's up to the hospital to get the information to your identified provider, and it depends. Some states will send a letter to the family and some don't. But anyway, when you get, or in the hospital, as I started to say, gets the information to the provider of the newborn care. The What I want to make a point of is when they tell you that the newborn screening showed that your baby has sickle cell disease or sickle trait or some of the other abnormal hemoglobin conditions that this test picks up. It's important. Don't ignore it and don't forget about it. Please don't ignore it.
And
So
I
that's
just want to add also historical context. This was also one of the justifications of why African Americans initially were not allowed to join the Air Force before World War II. Um, then us that the thought was the sickle cell trait made African Americans especially vulnerable to a whole host of different conditions, and actually was used to exclude folks from professional athletics, when in fact the rates of trait in the professional athletics is frankly not much different from the general population of African Americans.
and Dr. Walsh, I know, is director of public health in DC. Many of these young patients, especially, come in with a lot of pain. And do they get the pain medicine they're supposed to get? How do we handle the crisis? And is that a public health problem?
Well, I think we have a couple of public health problems when it comes to sickle cell. One is what you talked about, Dr. Maxey, which is the unequal care, historically well documented, for folks who do have crisis and who are very, very, very uncomfortable. The other thing is, I have a very good friend I've known for many, many years who suffered with sickle cell well into his 40s and was able to be quote unquote cured with the new treatments that they have. And this is life changing for this man and his family. The point I want to make is when he was trying to get into the study, they told him that he was too old. They weren't taking people of that age. He persisted, he was able to get in, and his life has been transformed. With the way things are going now at the federal government level, I think that we are going to have to, one, be aware that there are treatments that can completely change the life of someone who suffers with sickle cell disease. And we're going to have to fight for it. We're going to have to fight to not have that go away as people stop research and as people stop looking at things that maybe affect only us. I can see in the corner that next slide, and I see who is impacted by sickle cell. And can we go to that next slide that shows oh, Dr. Maxey, did you forget to put in the block for white? No,
No,
you did. No,
they're
you did not.
not
And
even in
and
the
and
race.
and I think that this is one of those things where y'all know I kind of tread on the political line a little bit. I don't want to blame stuff on that, but this is one we have to pay attention to. Look at this slide, take a mental picture of it, take a snapshot with your camera, and keep it, because this is our opportunity to fight for something that is going to transform the lives of many of us and save the lives of people. People die from sickle cell.
Right.
So we have to be very careful that we don't let what we've just gotten in terms of a treatment go away.
All right. Well, thank you so much. Let's go to the next slide. obesity. So obesity is a problem for everyone, but it tends to be an even larger problem for us in our communities. It causes weight pain, I mean, weight gain, joint pain, fatigue, and increased risk of sleep apnea, diabetes, hypertension, and fatty liver disease. It's something that we all think we know what it is. It's not just being big, but it's something that can affect all of your body. We used to use something called BMI, basal metabolic rate of above 30 to say you're obese, but that doesn't define people like the guys in the NFL who are not necessarily obese, but they have heavy density and they wouldn't pass his BMI test. But we typically say that for a man when his waist size is more than 40 inches, or a woman whose waist is more than 35 inches, that means that they have central obesity. So there are two shapes. There's the shape of a pear and the shape of an apple. It's better to be the shape of a pear and have a big booty and the thin waist, but you don't want to have abdominal fat so you look like an apple because that implies that you've got fat around your internal organs, and that can be deadly. It can affect your metabolic self. It can cause diabetes. It can cause liver fat, Cushing's disease, and it's something that we recommend for some people. If your weight is above that uh, BMI of 40, you may need to have cosmetic surgery or bariatric surgery. But nowadays, we can get a good weight loss with some of the drugs like Ozempic and the SGL1 drugs for obesity. And look at the next slide, Simon, with the graph. And it shows that we have an awful lot of obesity and it can cause major risk. And even though we say that many people are in food deserts, sometimes the high calorie, high processed food leads to more obesity in our community than it might in communities that have access to better food. Dr. Lawson, will you take the next slide?
Yeah, I just want to say very quickly about obesity, as one who has suffered from it, that it's often looked at as a willpower issue. And we now begin to recognize that this is a chronic illness that we still had to convince folks the need for treatments, not just surgery, but we also have medications. When you stop them, you go right back to the same behavior again. So this is in many ways, a chronic illness that requires as much intervention as and it's not just the eating, but also it must be combined with exercise to get some good results.
Let me ask you a deeper question. Does this have to do with the ventral medial nucleus?
Of course. I used to, yeah, and I used to do research with animals with this as well. And I'm not going to give another whole lecture on that, but not right now. And I
So,
just and I just also might add, again, guess what? Obesity is also tied in with depression. What they call interacting. Depression is a risk factor for obesity. Obesity is a risk factor for depression. Treating one often affects the other.
so let me just add real quick, Dr. Maxey, that recognizing, pointing out, and helping out with obesity is not body shaming. We get into these cultural spaces where somebody thinks that something is uncool, and then we don't get to talk about it. We have to continue in our community to talk about the dangers and consequences of obesity. And it is not body shaming when you are trying to point out to someone that they can be healthier. At least I don't think it is.
That's a good point. Good point.
And I might also add that we got all kinds of names to unrecognized obesity, big bone, and athletic. But a lot of times, even in the NFL, if you look at the life expectancy of NFL players and also professional wrestlers, who are many are in fact athletes, they die young. And a big factor is, along with the increased muscle mass, they also increase adipose tissue as well. And it's not just the fact that after they stop eating, they gain weight. They had heavy weight all the time. And all of that is putting a lot of pressure on the heart and other internal organs.
Yeah.
And Dr. Wolf, you take the one on AIDS.
Yeah. So
Yeah.
HIV, oops, you got it?
So I
That's
got it.
Okay.
So so HIV AIDS symptoms. Uh Early, you have a flu-like illness. And then you have chronic lymphadenopathy, those little spots along your body that are lymph nodes that suddenly you can feel that you can't feel most of the time. Weight loss, diarrhea, night sweats, opportunistic infections, PCP pneumonia, TB. Basically, your immune system stops being able to fight stuff and you get stuff that you wouldn't ordinarily get. Um, some of the diagnostic pearls, things to look for. HIV antigen antibody test is first line, and you confirm with HIV 1-2 differentiation assay, monitor your CD4 count and viral load, screen for co-infections, HBV, HCV, TB. Uh, Basically, what I'm reading in this first part of this slide is you can't figure this out yourself. If you are chronically feeling sick or and getting sick, somebody needs to check this for you. You can't say things like, well, I've never done this or I've never done that. HIV may not be as talked about, but getting it and not treating it, it's a bad thing. Um, so you want to screen for co-infections. The treatment is immediate initiation of ART, regardless of your CD4 count. Modern regimens include integrase inhibitors. The goal is an undetectable viral load, PRP for high-risk individuals, monitor for resistance and adherence. And I just want to point out that a lot of times people think that HIV is something that is just a horrible death sentence. And it's certainly not something that you want to ignore and just pass around and pretend it's not a problem. But I always look at Irvin Magic Johnson, who played for the Lakers and is still my favorite point guard. And he has lived a long time with aggressive intervention and just has had an impactful life. Not just he's lived, but he's taken that time that he got and has done a tremendous amount across many different communities. So none of the things that we talk about automatically have to be a death sentence. It's
Yeah.
important that we care about our health and preserving our health. And HIV is a really good example of people who got it early and tried their best to take care of it and lived long enough to where now they take some medicine and they're fine. They go on about their lives.
Let me also
So,
say that it deserves treatment by a specialist. There,
mm,
there are doctors that specialize and have an expertise in treating HIV as a very sophisticated disease and affects all of your body. But you want an HIV specialist for somebody, they come up with a new medicine every 3 months.
right,
And
right.
each one is better than the other. It's very important to do that. And it's also important with how this is spread. And even though the majority of it is spread by having sex, uh, anal sex, but also can be spread in different ways. And sometimes it can affect newborn babies. So it's something that you don't want to play with. You want to seek expert attention and also know how sex plays a role in it, not making any social judgment on how you have sex. But safe sex is the best treatment for HIV. It's going to,
Dr. Maxey,
yes.
just add to that, and I think that's an excellent point. There's a lot of stigma attached to it. It's still, unfortunately, very common in our community. And part of it is that people, as you said, people don't talk about it anymore. And yet it is very much around us, and we need to educate each other about the risk for it and take the precautions against it. It is not, and one of the theories is that, of course, that is related to illicit bad behavior such as sex or drug abuse, when in fact, people like Arthur Ashe, you can get it from transfusions. They used to think it's a young people's disease. It is not. I had a prostitute who regularly frequent nursing homes because there were men there who wanted to get their sexual needs met and who had extra money. So it unfortunately is very common among people over 40, especially African American women who are over 40. And it is also a condition that we now have preventive techniques that are extremely effective. And we have treatments that can allow people to have a normal life expectancy.
Now, that reminds me, I read an article a while back that said the highest rate of STDs happens in nursing homes. I wonder
Yep.
about that.
Yep.
That's Neighbor Stevens.
Well, I was just going to add that if you look at the hot spots in Florida, the hot spots in Florida are in the areas with large retirement communities.
Mm. Oh,
Does that all of Florida a hotspot? Never mind.
There are some hotter than other spots.
that's Neighbor Stevens was prostate and breast cancer.
Why, certainly. Prostate and breast cancer. It's interesting that you put the two together. And I'll explain my comment. Um, with prostate cancer, prostate, like breast cancer and like many cancers, can be sitting there growing and getting spreading for a long time before you realize you have any symptoms from it. Breast cancer, that lump can be there for a long time before you find it. In prostate cancer, well, with problems with the prostate, the one of the first symptoms can be changes in the urinary stream. You can either have a weak stream, a hesitant stream, even having to work harder to push out the stream.
Does that mean you can't hit the mark on the wall anymore?
That I was, I used to tell parents when they're doing toilet training that the daddy needs to take the little boy in the bathroom and they should put a piece of toilet paper in the commode and aim for the target. Um, so yeah, you won't hit the target anymore. You'll be dribbling all over the place. Um, Advanced prostate cancer, unfortunately, is a very bad sign. It tends to metastasize to the bones as well as to other parts of the body. But the good news, and those of you who are regular viewers know, we've had 2 or 3 talks on prostate cancer, and the approaches and the outlook on prostate cancer is changing because of new treatment advances. But at the end of the day, the most important thing is to find it and to find it as early as possible. So, screening at the appropriate age for men, and that's a controversial topic. Typically, the types of cancer that occur in African American men, or I should say frequently, the the type of prostate cancer that occurs earlier than it occurs in non-white men, and it's more aggressive, meaning that it gets worse faster. Um, in breast cancer, almost the same story. That in certain types of breast cancer, it occurs in African American women earlier and it's more severe. Um, the key with both of these is early detection and appropriate treatment. Want me to keep going?
There's one more slide on that. Just a graph.
Now, in prostate cancer, and I'm betting that the breast cancer one is going to be very similar, if not identical. The prostate cancer and breast cancer is not necessarily, in fact, usually, It's not more deadly, it's just found later. So it's already gotten ahead of us. That's the problem. So the takeaway on this is follow the schedule of those recommended screenings. They were created because it was identified that if you started those screenings at those points in your life, if you develop one of these cancers, it'll be picked up earlier. And the same story with colon cancer. It'll be picked up earlier with a greater chance of treatment and cure.
Let me make a comment too. I had a patient just last week. He was a 68-year-old Black man, and he had prostate cancer. For 28 years, he had been fooling around with pellet therapy, enzyme therapy, estrogen therapy, radiation, and found it metastasized to his brain, his lung, his bone, and he finally just died. And I myself had prostate cancer some years ago, and I think I made the right choice, which I think if we get Dr. Sohn back on, that I believe the best treatment for most people is to take it out. After that experience with this gentleman who had so many failed treatments with non-surgical cancer, if you can get it out while you can, I believe that's probably still the best option. Some men are concerned that they won't be able to have sex anymore, but that's not necessarily true. Anyway, that's my thought. Anybody else want to comment on that?
Yeah, I just want to note you're absolutely right, especially with the kind of surgical process we now have, plus some newer techniques, very focused for surgery. You do not have to have the complications of urinary incontinence and sexual dysfunction that we've seen in the past.
Okay, and Dr. Walsh, I think the last slide in the series is stroke. If you take that one.
Yep.
Stroke symptoms.
Stroke symptom. Oh,
Oh, I'm sorry. That's coming.
Dr. Lawson is just anxious to anyway. I'm gonna leave Dr. Lawson alone. He's my brother. Stroke symptoms: sudden numbness or weakness, especially one side, confusion, trouble speaking, vision problems, loss of balance, severe headache. Diagnostic pearls: non-contrast head CD to rule out hemorrhage, MRI for ischemia. So we got two different tests, one to see if it's a bleeding stroke and one to see if it's a stroke because something got blocked off because the blood flow got blocked off. Um, Assess with the NIH stroke scale, identify the cause, carotid ultrasounds, echocardiogram, EKG for atrial fibrillation, treatment, TPA within a 4 to 5 hour window for an ischemic stroke to try to get the blood flowing again, and mechanical thromboectomy for large vessel occlusion. So you remove whatever is blocking the blood flow. We can go on to the next. Oh, here we go. Antiplatelets or anticoagulants, depending on etiology, long-term rehab, and risk factor modification. So fix the bad stuff that's been going on that you've been ignoring, like your high blood pressure or high blood glucose or smoking or lipids. One of the things I like about the way that Dr. Maxey puts these together is that there's none of it is ever hopeless. There's always a way for us to do better and have ourselves function better. So, and let's go to the next one. Let me see if Dr. Maxey finally has found something where we're not doing worse than other people. Nope, this isn't. So, it again, I say this, it is so challenging to look at all of these statistics and know that there's something that we can do as individuals and as a community to change the way this graph looks. And whatever the government's doing, whatever unequal treatment there is, I think we can I think we can do better. So that's
go to the next slide, Simon. And so this is an overview of health disparities. and African Americans. We know that we experience higher rates of chronic illness. We know that there are social determinants of health that we have a problem with. We know that early diagnosis and culturally competent as well as clinically competent healthcare is very important. We're going to focus on educating our communities, screening, and prevention is very important. So take action for better health. Know your risk factors, know what your family history is, get regular checkups and recommended screenings. I get all the vaccines that I can get and
Mhm.
maintain a healthy diet and exercise and manage your disease or your risk and advocate for equitable health care in your community. So real quickly, we've got about a few minutes left. I want to go to the second set of slides we have. I just want to run through those real quick. And I'm going to irritate Dr. Walsh a little bit when he sees the title of these. Simon, put up that second set. In the meantime, we can comment on what we just talked about. Dr. Neighbor Stevens.
You know, someone said something to me this morning, and I've been thinking about it ever since they said it. They said stupidity can be painful.
Mm.
Here at Black Health Trust, we are trying so hard to give you the information that you need so that you can take the actions that you need to take. And I think that that is as much the job of physicians as treating the problems that they find, if not even more so, trying to prevent them or to make them less severe. So I don't think we can ever talk about these topics too much because the graphs show that it's not going down.
Mhm.
Okay. We're not going to go into detail here, and we'll save this for some of next week, but we're going to talk about U.S. mortality and African Americans versus whites. Go to the next slide, Simon. And I'm having trouble reading, so if you make it as big as you can. So this is population share from 2019 to 2023. And I want to make a comment. It says whites, NH means non-Hispanic. I don't know why we always have to identify non-Hispanic. They have 58% of the population, and blacks have 13.7%. Age-adjusted death rate is white with 822 versus 1,002 per 100,000 people. Black, so we had 1.22 times the death rate of whites. And take that. What's that next one, Dr. Walks? Life expectancy.
Life expectancy at birth in 2022 for whites 77.5 years, for blacks 72.8 years, showing a gap of 4.7 years. Ooh, and infant mortality in 2023, whites 4.48 per thousand versus blacks 10.93 per thousand. So infant mortality rate for blacks is 2.44 more than whites.
Let's go to the next one. We can go pretty fast on these. Go to the next one. Okay. Go to the next one. Wait, let's look at this a minute. This shows our death rate is higher. Is that correct?
Yeah, this is a slide representing what we read in the first slide. Um, and you're right, Dr. Maxey. These are not making me feel good looking at these slides.
Next slide. Okay. We just went through all this, but the leading cause of death is that kidney disease?
Yep.
Okay. And people with kidney disease, they don't die from the kidney disease, they die from the heart disease. Let's go to the next slide. You can go past this one. Dr. Neighbor Stephen, you want to comment on this?
Well, we have talked about high-risk pregnancy and different chronic diseases impacting women of childbearing age. All of that plays into why we have such a high infant mortality rate. We have a high prematurity rate, and the moms come into the pregnancy with multiple types of chronic diseases, which puts them in the high risk category, which then leads to premature deliveries. And that's the primary driver of our newborn mortality is prematurity.
Hey,
So,
next
so,
slide.
before we leave this slide, every time I see this information, it hurts my heart because I love track and field and I loved Tori Bowie, who was the fastest woman in the world at one point, represented the United States, famous internationally, and died alone with a disastrous childbirth situation. And I think if someone that's famous and representing this country, like Tori Bowie, can die alone with a horrible birth outcome, we really have to look across our communities at the people that we see and make sure that folks know that it ain't just ordinary. I'm gonna get pregnant and have a baby. There's a whole lot more to it than just that.
And it's just because you're educated, just because you're rich, if you're a Black woman, you're still at a very high risk of having problems, and the babies are at a high risk for death.
Didn't something happen to the tennis player lady, Sabrina?
Serena,
Serena.
Hers was a postpartum issue.
Postpartum depression. But yeah.
No, she had a PE,
yeah.
and they refused to listen to her until she just demanded that they get her attention, pay attention to her, and they finally managed her pulmonary embolism.
Let's go to the
And
next slide.
again, everybody's not Serena Williams
Let's
that
go
can
to,
demand and pay and get listened to. So we and anyway, I was just going to repeat myself and I'm just going to upset myself, so I'm going to be quiet.
go to the next slide. We're going to go fast as we can, Simon. Next slide. Dr. Lawson, you want to take this one?
Yeah, I think it's pretty much what we roughly recognize. There's a geographical political implication. This shows geography, DC, which is a city, but still, these states are those in which we have large percentage of black folks. But not only a large percentage, but also it shows that those in which the high percentage of black folks also tend to have a greater black-white life expectancy gap. I might also add that you might have a slide at some point internationally, because again, a lot of what we're seeing in the U.S. simply does not exist in other countries.
Yeah, I'm making a point. Keep going. Let's go to the next slide. It's better to live in California than DC. So interpret this slide, Dr. Walks.
um, Interpret this slide.
And think of the
Things aren't
pandemic.
getting better. Things aren't getting better. There, that's it. I interpreted the slide. Things are not equal and they aren't getting better. The gap, it don't we want to see the gap getting getting less and less until the two lines are the same place, Dr. Maxey?
That's what we want, but
Okay.
let's
So
go. We don't want to get into
like I
politics,
said,
right?
like I said, things aren't getting better. Next
Next
slide.
slide. All right. Well, let the slide speak for itself. Next slide.
So wait a minute, Dr. Maxey. So this shows that maybe things are getting a little better, right?
Yeah. After COVID.
Right.
See what that
Right.
COVID did?
Yep.
Yeah.
Next slide. Now, we talked about diseases, but look at this. Go to the next slide. And all the time I was doing this, I was thinking about Dr. Walsh and Dr. Lawson. Read this slide, Dr. Lawson.
Yeah, executions, 1,635 shared by race. Well, I guess I don't know if that's good or not. White folks more likely to be executed. Death sentences imposed 9,930. Only 16.5% of death sentences have resulted in only in executions, and relative to 2020 population, the black folks tend to be more likely, and we've known for some time.
So
The
can we
main question is that fourth statement says relative to 2020, black defendants were 2.73 times more expected to have a death sentence.
so hold on, Dr. Maxey. Let's go back to that second bullet, because a lot of times we get information put at us and it's given to us in a way that
Mhm.
that we have to pay close attention to how things are reported. Because when we look at share by race, white 55.9, black 33.9, we may say, oh, well, maybe that's not. No, that's out of that number. And you put that up against the population percent, we are only 13.7%, if I remember from that previous
Right.
slide, of the population. So if we're only 13.7% of the population, why are we 33.9% of the folks getting executed?
That's why I
This,
brought it down to the last bullet.
Yeah.
okay,
Look
okay,
at it.
It's
Read
because
by
that,
don't,
relative race.
read that last bullet.
no, I see the last bullet, but not everybody's going to see the whole slide, Dr. Maxey. The point I'm making is people try to take bits of information out of context, out of the slide, and trick us. And we have to be, that's why Black Health Trust is so important. We have to be willing to take a minute and look at things and interpret and identify and call out when stuff is being presented in a way that doesn't motivate us to get things done. So I'll finish my rant next time.
Very right. Next slide. Okay. Who's had more? What does this one say? I can't read the bottom.
Dr. Maxey,
This,
I
this
would
is the
like to
same point
I
you're
would like
making.
to
This one,
recommend that you take this slide out, because this slide again makes it look like we're not being executed more often,
okay, let's
and
go
we
to the next.
are.
Let's go
Well,
to
yeah, you got to control for population percentage.
okay, go to the next one. Go to the next one.
That's more like it.
Yeah.
Okay.
Thank
Yes.
you.
Dr. Walks, you take this one.
They're killing us. Next slide.
Next slide.
No, okay, wait a minute. Okay, Dr. Maxey, in all seriousness, the reason that these slides bother me so much is because we know that the system that takes us from arrest to execution is an unfair system. So when you look at the fact that we are go go back to what is it Dr. Kanjufu talked about, when you go right way back to black boys being 10, 11, 12 years old, and all the way from there to these execution numbers, it's not right.
Okay. Let's go to the next slide. We're almost done. Next slide. The next slide. Let's go to the next slide.
Okay.
So read this one.
Awful.
Next slide. Let's go to the next slide, Simon. Okay. So the main point I was making with these slides is that we saw the things that we're naturally affected by with our disease mortality. Then we went to what happens with mortality in general. Then we went to mortality by government. And we know that we also, the one thing that I didn't do, we may do it another time, is what happens when you cut out Medicaid, when you take 17 million people off of health care and you kill that many people during the pandemic. We know that all this stuff works together and is purposeful. So we are trying to be exterminated by, I won't say the general public, but by the people who are in charge right now. So this is not something that we should sit down. We have to take care of ourselves. We have to know that this is a war. This is purposeful and it's done on purpose. We have time for a few comments and we'll see you next week after that. This, Dr. Lawson, you care for a final
Very
comment?
quickly, make the point I made all the time, every time. Please include the mental health statistics as well, because the disparities you see there are also disparities in terms of depression, suicide, homicide, and most importantly, every one of the measures that you have when you look at people who have depression, the mortality rate shoots up. And also, a lot of those folks who are sitting on death row, a disproportionate number of those have mental disorders that are unrecognized and untreated.
Dr. Walks?
Dr. Maxey, I think I made enough comments during the course of of today's program. And the one comment I want to
I
make
like
is,
your passion.
well, I mean, I am passionate about this and I talk about how things bother me, but this is really not about me. This is about ongoing bad news for our larger communities, because we are very diverse communities. And I think that all of us need to get a little bit more uncomfortable given the direction of our policy at the national level at this point. We should be even more uncomfortable about the fact that one of those last slides you showed, Dr. Maxey, was April 2025. That's not a long time ago. That's not an old slide from 1970. So I think we need to be aware that these are current situations, and they really demand current active participation in trying to change those numbers.
Thank you. Dr. Barbara Davis Stevens.
I echo the sentiments of everyone and just would sum it all up with we got a lot of work to do.
Mhm.
That's true. I debated bringing up one more issue before we get off, and we'll make it short. But I read an article today. It's something that just happened the 25th of last month. They executed a guy named Byron Black in Tennessee. And I read through the whole case, and it turned out that he got convicted 37 years ago of murdering his girlfriend and her two children, one who was 9 and one was 6. And he claimed that he was intellectually disabled and wanted clemency on that fact. And it brought up the whole thing of capital punishment, which we know is probably incorrect, especially when you have so many juries that if you're black, you're guilty, if you're white, you're okay. But that's something that bothered me, because I know somebody murdered my grandchildren, I'd be very upset. But that's just something that bothered me. Between many of us want to make sure we don't just let people hurt our families, but at the same time, we don't want unjust judgments given against our people. Anybody care to comment on that in the last 3 minutes we have before Dr. Barbara Neighbor pulls the plug?
Well, I just want to say that it was actually this week that all of that went down. And what makes the whole thing is complicated, but what adds to the complexity is that he had a pacemaker, a
Yeah.
pacemaker,
And a
and
defibrillator.
and they want his attorneys said, well, if you're gonna execute him, at least you know, we need to do something about the defibrillator because that's going to make the execution prolonged. And there was a lot of back and forth around that, and they left it in.
Our two psychiatrists care to comment?
Well, I just want to quickly say I'm not sure what public health or social problem was solved by this prolonged effort to get him executed. What in fact did society aim? You say it's supposed to protect society. There's frankly no evidence that executions do that. And again, many countries don't have executions, and their murder rate, homicide rate, and everything else is much lower than the United States.
Dr. Walsh, final comment.
What Dr. Lawson said.
Okay. Thank you, Simon. Have a great day. Thanks for joining us. We'll be back next week. Have a great day. Have a good day.
Hey, everyone.
Bye, everyone.
Bye.